We're going to go ahead and get started. It's a great pleasure to have Dr. Callegan-Poche presenting today. She's a native of Louisiana, having attended LSU Baton Rouge as an undergraduate. Go Tigers, #1, huh?
Absolutely.
All right. That's hard for a Texan to say, but I'm excited about that. She did medical school with us, did her med peds, and was the chief resident this last year before joining us as faculty. Let me just say how excited I am to have a young faculty being one of the people up here presenting. I think that's really what we're excited to see, and on such an important topic. So thank you for joining us and sharing this information.
Can everyone hear me? Okay. All right, so today the name of my presentation is Do Ask, Do Tell, Treating LGBTQ plus patients in the primary care setting. I can't take credit for the Do Ask, Do Tell. That's the Fenway Health's slogan that they used in order to promote the open lines of communication between these patients and their providers. So I don't have any disclosures today. Our objectives, we're going to define various terms that clinicians should be familiar with in order to provide LGBTQ-friendly health care. We're going to identify the various barriers to health care for these individuals. We're going to describe important components of taking a sexual history. And then finally, we're going to go over preventative care guidelines for this special patient population. So researchers have estimated that approximately 3.5% of U.S. adults identify as lesbian, gay, or bisexual, and about 0.3% of those identify as transgender, which amounts to approximately 9 million individuals in the United States. In one survey of 15 to 44-year-olds, 12.5% of women and 5.2% of men did report a history of same-sex sexual contact, and so it's likely that we've encountered these individuals in our practices whether or not we're aware of their orientation or gender identity. So let's talk about some definitions, starting with LGBTQ+. So that acronym stands for lesbian, gay, bisexual, transgender, questioning, or queer, and the plus kind of includes everything else, including pansexual and asexual. Sex refers to the biological markers and anatomic characteristics, including organs and genitalia, and we are assigned one of two sexes at birth, male or female. So gender identity is a person's internal sense of being a male, female, both, neither, or another gender, and for most people, their gender identity does correspond with their assigned sex at birth, and we term that cisgender. Transgender people, however, have gender identities that do not correspond with their sex at birth. And then people whose gender identity falls outside of that gender binary, being male or female, they may refer to themselves as genderqueer, gender fluid, non-binary, or other terms. So some terms for transgender. Transition refers to the process and time when a person goes from living as one gender to living as another gender. Transgender persons who are assigned a male sex at birth but identify as female may call themselves transgender women, trans women, or male to female persons. For people who are assigned a female sex at birth but identify as male, they're known as transgender men, trans men, or female to male persons. And they may alter their physical appearance, often through hormonal therapy and or surgery, in order to affirm their gender identity. Sexual orientation is how a person characterizes their physical and emotional attraction to others, and there's 3 dimensions. So attraction and desire, and that's the gender that a person is attracted to. There's also behavior, that's who the person is having sex with, whether it be men, women, or both. And then there's identity, so how they see themselves. Do they consider themselves gay, lesbian, bisexual, straight, queer, or something else? We cannot infer an individual's sexual identity based on their behavior. So lesbian typically describes women who are emotionally and sexually attracted to women mostly. Gay describes men who are emotionally and sexually attracted mostly to men. Gay is sometimes used to describe all people who have same-sex attractions. Bisexual describes people who are emotionally and sexually attracted to both men and women. Heterosexual or straight describes people who are emotionally and sexually attracted to people of the opposite gender. And then MSM, or men who have sex with men and women who have sex with women, WSW, those are terms that are often used in the clinical setting. Pansexual describes a fluid sexual attraction to people of any sex or gender. Asexual describes a person who does not feel sexual attraction. And then queer is kind of this umbrella term that can include essentially the entire LGBT community and those who kind of fit outside social norms of sexual identity and gender expression. And so queer kind of emphasizes fluid and experience-based attractions and identities. Gender expression is how someone demonstrates their gender through behavior, mannerisms, speech patterns, dress, and hairstyles. This is the Genderbread Person. This is actually the first version. This is just kind of used to understand better gender identity, expression, biological sex, and sexual orientation. This is the first version. There is a fourth version now, but it's much longer and it wouldn't fit on my slides. But you can go to genderbread.org and you can see all the different versions, and there's patient education material and all there. So gender dysphoria is distress that's experienced by individuals whose gender identity does not correspond with their assigned sex at birth. It can manifest itself as clinically significant distress or impairment in social, occupational, or other important areas of functioning. It can emerge in childhood, adolescence, or adulthood. If it emerges in childhood or adolescence and kind of persists through that adolescent period, then it's usually going to persist long term. Many gender dysphoric children become homosexual or bisexual, but not transgender as they go into adolescence and adulthood. And not all transgender people experience gender dysphoria. So we're going to move into talking about the barriers to healthcare, because we want to reach for health equality and we want to reduce health disparities for this patient population. So due to fear of discrimination, past negative experiences with healthcare providers, and or false beliefs about healthcare screenings, many in this patient population do not seek needed medical care, which results in failure to detect and treat health problems early. So these are some of the health disparities seen. There are higher rates of HIV and other STIs, lower rates of mammography and PAP screening, higher rates of substance abuse, higher rates of unhealthy weight control and weight perception, higher rates of smoking, depression, anxiety, and higher rates of violence victimization. So LGBT populations have the highest rates of tobacco, alcohol, and drug use. LGBT youth are 2 to 3 times more likely to attempt suicide. They're also more likely to be homeless. Lesbians are less likely to get preventative services for cancer. And gay men are at higher risk of HIV and other STDs, especially among communities of color. Lesbians and bisexual females are also more likely to be overweight or obese. Transgender individuals experience a high prevalence of HIV, STDs, victimizations, mental health issues, and suicide. And then elderly LGBT population they have additional barriers. They often experience more social isolation. They have fewer family supports, and they just don't have as many social support services. So some patient barriers to medical care. These patients are often economically disadvantaged. They don't have health insurance. Again, they're socially isolated. There's this fear of discrimination. They've had negative past experiences, and they have false beliefs about their healthcare screenings. Other barriers include lack of provider training and competence, overt or covert harassment by providers or support staff, lack of support and training by clinic individuals, and then lack of LGBT-sensitive intake forms. So creating a welcoming clinical environment is key to attracting this patient population. So some things we can do, we can participate in provider referral programs through LGBT organizations such as glma.org or gayhealth.com. We can advertise in LGBT media. We can have universal gender inclusive restrooms, post LGBT friendly symbols, stickers, signs, etc. display brochures that have LGBT health concerns, and disseminate or visibly post a non-discrimination statement. Intake and history forms are a really good way to obtain information about these topics from patients. If they're available prior to the appointment, patients can answer them at home or in a much more comfortable environment. Again, they should include statements to ensure confidentiality, and this allows the physician to be more prepared prior to meeting the patient so that they can use preferred names, appropriate pronouns, etc. So these are some examples of intake form questions. So we can see, sexual orientation, identity. We have bisexual, gay, heterosexual or straight, lesbian, queer, other, not sure, don't know. Relationship status, so it's not just single, married, divorced. We have domestic partnership, partnered, involved with multiple partners, separated, other. And then for gender, it's not just male or female. We have transgender, we also have other. And so a lot of choices, being more inclusive. So for transgender people, we especially need to establish good rapport prior to discussing sexual practices or performing a physical exam. We need to use the patient's preferred name, use preferred pronouns, and then we need to ask what the patient may call their sensitive body parts and use those terms when referring to them. Okay, so we're going to talk a little bit about taking a sexual history. It is an important component of the history that's often skipped unless a patient has a specific complaint relating to sex or STDs. So there are several reasons why providers avoid talking about sex and obtaining a sexual history, so it can be uncomfortable for the provider and the patient. There is this fear of offending patients, especially transgender patients. We often don't receive adequate training in taking a sexual history. And then providers may also worry about identifying a problem that they don't know how to treat. But patients want to talk about sex with their providers. So in a survey of 500 men and women over 25, 85% expressed interest in talking to their providers about sexual concerns. But more alarming was that 71% thought that their provider would actually just dismiss their concerns. So taking sexual histories will allow us to answer questions, educate, and counsel patients, and it's a key component that should be taken at least annually. So again, keys to taking a sexual history, you need to let your patient know that this is something that's done at least annually. It's part of the routine that care that you provide all of your patients. You want to avoid assumptions, be non-judgmental and supportive, use gender-neutral language, be specific with your questions, and again, assure confidentiality with patients. So this is just a little algorithm for conducting a sexual history. I'm not going to go through it all, but basically the 3 screening questions that they recommend you can begin with: have you been sexually active in the past year? Do you have sex with men, women, or both? And how many people have you had sex with in the past year? Now, the CDC has developed the 5 Ps to taking a sexual history, and those include partners, practices, protection from STDs, past history of STDs, and then pregnancy plans.
Amanda, when do you start doing that with
adolescents? Adolescents, so generally I start as early as 11 years old. So I start 10 to 11, I start asking parents to leave the room. And I explain to parents that this is part of growing up and becoming an adolescent. I do it with all my adolescents, and I get them to step out of the room. Generally, when they're that young, I'm more asking, have you heard of sex? Are there people, are your friends having sex? Things like that, very vague things. And then as they get older, 14, 15, 16, that's when I'm asking more, have you figured out, if you like boys, girls, or both? Have you ever had any type of sex? And you have to be very specific with those teenagers, but yeah.
So you let them know they can talk to you.
Absolutely, yeah. I always start off with anything you say to me is just between me and you. You're my patient. Unless you're planning to hurt yourself or hurt someone else, this is just between us, and I'm not going to tell your parents. And that way they're comfortable talking to me. And sometimes even then it takes a couple times doing that for them to open up. Okay, so in terms of partners, you want to ask if their partners are men, women, or both, how many partners they've had within a time period. Some places recommend 2 months, some recommend the past year. If both, who are they currently sexually active with? And if both, how many female and male partners have they had? Is it possible that any of their partners was having sex with someone else while they were engaged in a sexual relationship? And then asking about physical, sexual, or emotional violence and abuse from their partner. So practices, asking about the kinds of sex they're having, ask if they've had anal sex, do they give or receive it, if they or their partners have ever used drugs, injection drugs, if they or their partners have ever participated in transactional sex, if them or their partners have ever been incarcerated, if they use alcohol or drugs when they have sex, or does their partner, and if they have any concerns about their sex life. Protection from STDs, asking what they do, if they use condoms, and if they say yes, if it's always, sometimes never, if never, why they don't use condoms, if only sometimes, in which situations do they use condoms, asking when the last time they had unprotected sex was, and asking about their partner's past sexual activities and whether they use protection from STDs. And then a past history of STDs, if they were ever diagnosed, if they have any current symptoms, if they have ever been tested for HIV or other STDs, if they would like to be tested, and then again, getting their partner history if their partner had ever been diagnosed with an STD. And then pregnancy plans, so asking their plans or desire to have children, asking if there's a need for a contraceptive, if they want information on contraception, and if they're currently doing anything to get pregnant. And then this is the last, it's not really part of the 5 Ps, but asking patients if they have any concerns about their sexual function, if they've had any changes in their desire or satisfaction, and again, just any concerns or questions about sexual orientation, identity, or desires. Okay, so now we're kind of going to dive into the bread and butter of my talk, and we're going to go into prevention and screenings. So specifically for the transgender population, I didn't go into, all the treatment and hormonal therapy and all those guidelines. There is an excellent resource through Fenway Health, actually, that goes into that. It goes into side effects of all the therapy, lab monitoring. If you're actually interested in doing hormonal therapy, there's actually informed consent forms in there that lists all the risks and expectations of therapy. And so it's a good resource. But I did want to touch on some of the side effects and monitoring that we should be doing as we are seeing more patients on hormonal therapy. And as primary care providers, I feel like we need to know kind of what to look for in patients that are on these. So for estrogen therapy, risks include venous thromboembolism, weight gain, decreased libido, increased triglycerides, elevated blood pressure, decreased glucose tolerance, and a risk of diabetes, gallbladder disease, possible increased risk of breast cancer, and infertility. And then for testosterone therapy, lower HDL, elevated triglycerides, hepatotoxicity, polycythemia. They can get a chronic pelvic pain. There's really unknown effects on breast, endometrial, and ovarian tissues. There's an increased risk of sleep apnea, insulin resistance, and infertility. So this is the recommended lab monitoring in patients who are on hormonal therapy. So for transgender males, it's recommended that you get CBC lipids and LFTs at 6 months and then every 6 to 12 months. Consider glucose and or A1C every 6 to 12 months in those with suspected PCOS at baseline and in those who are at risk for developing diabetes. And then a serum testosterone you can get 6 to 12 months after initiating therapy if you do a dosage change, 2 to 6 weeks after that dosage change, and then yearly if they're on a stable dose. Transgender females, if they're on spironolactone, you want to monitor potassium and BUN to creatinine 2 to 8 weeks after starting or changing their dose. Lipids, blood sugar, electrolytes, BUN, and creatinine at 6 months, and then every 6 to 12 months, and then a serum prolactin yearly, as estrogen therapy has been shown to increase serum prolactin. So cardiovascular disease, so a lot of studies suggest that risk is unchanged among transgender men using testosterone compared with non-transgender women, but the evidence in transgender women is less clear. Some studies have shown an increased morbidity and mortality. Sorry, my battery's dead. Can everybody hear me okay? Okay, I'll just go without it.
Can they hear you?
They won't be able to hear you.
I'll just fix it for you.
Okay. Thank you. Okay. All right, she's going to get that, but I'll continue on for now. So those studies that did show an increased risk in morbidity and mortality, they actually didn't really adjust for other risk factors like tobacco use, obesity, and diabetes, which we know has been higher in this patient population. And so take that with a grain of salt. Depending on the age at which the hormones are begun and the total length of exposure, providers can choose to use the risk calculator for natal sex, affirmed gender, or take an average of the two. There's no real good, set guidelines for that. And then for transgender women who do have cardiovascular disease risk factors or established disease, then using a transdermal route of estrogen may be preferred due to lower rates of DTE and lack of changes in lipid profile or markers of coagulation. It's still not working, so. Okay, as far as diabetes goes, so I'll talk mostly about USPSTF guidelines because that's what will be on your boards. So the USPSTF is going to recommend screening for abnormal blood glucose as part of cardiovascular risk assessments in adults aged 40 to 70 who are overweight or obese. And then obviously clinicians should refer or offer patients with abnormal glucose behavioral counseling interventions in order to promote a healthful diet and physical activity, and that's a grade B recommendation. Tobacco and drug use. So again, like we said, there is higher rates of tobacco and drug use among this patient population. So the USPSTF does recommend that clinicians ask all adults about tobacco use, advise them to stop using tobacco, and then provide behavioral interventions and FDA-approved pharmacotherapy for cessation to those who use tobacco, and that's a grade A recommendation. For illicit drug use, they recommend screening in adults 18 or older, and they say that screening should be implemented when services for accurate diagnosis, effective treatment, and appropriate care can be offered or referred. And that's a grade B recommendation. So I guess if you don't have any resources to provide them, don't screen for it, is what they're saying. Cancer screening. So at this time, there's insufficient data to determine if transgender persons are at increased or decreased overall cancer risk. And there's also insufficient data regarding particular organ-specific cancer risk. But as a rule, if an individual has a body part or organ and otherwise meets screening criteria, then you should screen them regardless of their hormone use. And then screening should not occur in those with limited life expectancy or those with an inability or unwillingness to undergo treatment for that cancer. So colorectal cancer screening, same for everybody. So colorectal cancer screening should be performed in all adults beginning at age 50 and continuing until age 75. And that's a grade A recommendation. And I'm not going to go through that, but that's the different colorectal cancer screening strategies. For lung cancer screening, so the annual screening with low-dose CT in adults 55 to 80 years of age who have a 30-year smoking history and currently smoke or quit within the last 15 years. And that's a grade B recommendation from the USPSTF. All right, can everyone hear me again? All right. And then for the lung cancer screening, it can be discontinued once a person has not smoked for 15 years. All right, for cervical cancer screening, so that applies to all individuals with a cervix, which includes transgender men. So these are the grade A recommendations for from the USPSTF. So those 21 to 65 should be screened with cytology every 3 years. If they're age 30 to 65, then you can do screening with cytology and HPV co-testing every 5 years. Those with HIV should actually be screened twice within the first year after initial diagnosis, and then if that's negative, you can go to annual screening. Ovarian cancer screening, so the USPSTF recommends against screening for ovarian cancer in asymptomatic women, and that does not apply to women with known genetic mutations that increase the risk of ovarian cancer. There's no evidence to suggest that transgender men are at increased risk of ovarian cancer, and so they should just follow the same recommendations as cisgender women. For breast cancer screening, screening mammography with or without a clinical breast exam is recommended every 1 to 2 years for women 40 and older, and that's a grade B recommendation. That applies for transgender men who have not undergone bilateral mastectomy or who have only undergone breast reduction. And then there really are no current guidelines that recommend screening for transgender men who have undergone bilateral mastectomy, and they say that you may just consider annual chest wall exams. For transgender women, screening mammography should be performed every 2 years once the age of 50 and they've had 5 to 10 years of feminizing hormone use. Once that criteria has been met, you should start screening them. For prostate cancer, the USPSTF recommends against PSA-based screening. Removal of gonads in addition to estrogen exposure likely reduces the risk of prostate cancer and BPH in transgender women. PCPs, however, should remain aware of the possibility of prostate cancer in transgender women, and if a prostate exam is indicated, rectal and neovaginal approaches may be considered. When you do a PSA test in transgender women with low testosterone levels, you may need to reduce the upper limit of normal for those tests. Testicular cancer screening, again, the USPSTF recommends against screening for testicular cancer in adolescent or adult males. Again, the risk of testicular cancer is likely reduced with androgen suppression, so there's no recommendation for screening in transgender women. For transgender women who have persistent elevations of testosterone despite being adherent to therapeutic doses of estrogen and androgen blockers, then you should evaluate for a testicular tumor with physical exam, HCG, AFP, and LDH levels. So osteoporosis screening, the USPSTF recommends screening women 65 or older, and then in younger women whose fracture risk is equal to or greater than that of a 65-year-old white woman with no additional risk factors. Risk factors for fracture do include advancing age, a previous fracture, chronic steroid use, a parental history of a hip fracture, low BMI, current cigarette smoking, excessive alcohol consumption defined as greater than 10 drinks per week, hypogonadism, rheumatoid arthritis, hyperparathyroidism, immobility, vitamin D deficiency, and HIV infection. And then transgender, so that's a special population in regards to osteoporosis screening. So if transgender people have undergone gonadectomy and have a history of at least 5 years without hormone replacement, then they should be considered for a DEXA scan regardless of their age. In female to male patients, they should be screened beginning at age 50 if they've been on testosterone for more than 10 years. If not, then they should begin screening at age 60. For male to female patients who have remained on hormone therapy and have no other risk factors, they do not need screening. And then for male to female patients who have stopped hormone therapy after extended use, those patients should also be screened. So depression screening, the USPSTF recommends screening for depression in the general adult population, including pregnant and postpartum women. Screening should be implemented with adequate systems in place to ensure accurate diagnosis, effective treatment, and appropriate follow-up, and that's a grade B recommendation. So lifelong stigma, harassment, and/or discrimination is a major cause of chronic stress, depression, anxiety, and other mental health problems in this patient population. Primary care settings can offer a safe environment for these individuals to bring up their mental health concerns. Routine primary care visits should include screening for co-occurring mental health conditions, past treatments, history of suicide, ideas and self-injurious behaviors, symptoms of post-traumatic stress, and substance use. In one survey, 40% of transgender or gender-variant individuals reported having attempted suicide. And then intimate partner violence. So the USPSTF recommends that clinicians screen women of childbearing age for intimate partner violence and provide a refer to women who screen positive to ongoing support services. And that's a grade B recommendation. It's actually estimated that 50 to 100,000 women are battered by a same-sex partner each year in the U.S. And the CDC's National Intimate Partner and Sexual Violence Survey found that 44% of lesbians and 61% of bisexual women experience rape, physical violence, and stalking by an intimate partner, compared to 35% of heterosexual women. 26% of gay men and 37% of bisexual men experience the same as compared to 29% of heterosexual men. 46% of bisexual women have been raped compared to 17% of heterosexual women and 13% of lesbians. And then 40% of gay men and 47% of bisexual men have experienced sexual violence other than rape compared to 21% of heterosexual men. And then the 2015 U.S. Transgender Survey found that 47% of transgender people are sexually assaulted at some point in their lifetime. So this is huge in this patient population, and we really need to be asking these questions. All right, we're going to go into STI screening now. So for chlamydia and gonorrhea, the USPSTF recommends screening sexually active women 24 years and younger, and in older women who are at increased risk of infection, and that's a grade B recommendation. Those at increased risk include having a new sex partner, having more than one sex partner, having a sex partner who has concurrent partners, having a sex partner with an STI, inconsistent condom use in people who are not in a mutually monogamous relationship, if they've had a previous or coexisting STI, and if they're exchanging sex for money or drugs. And urine testing is typically preferred in transgender persons. There's no evidence to guide routine screening for chlamydia in transgender women who have undergone vaginoplasty. A screening interval of 3 months is recommended for those at high risk, which includes those with multiple partners, condomless sex, transactional sex, or sex while high or intoxicated. The screening interval is at least annually for men who have sex with men at sites of contact, including the urethra, rectum, and pharynx, regardless of condom use. And then for HIV-infected persons, their screening should be done at the first HIV evaluation and then at least annually thereafter. For syphilis, the USPSTF recommends screening in persons who are at increased risk, and that's a grade A recommendation. And risk factors include men who have sex with men, HIV-infected persons, a history of incarceration, and a history of commercial sex work. Again, transgender men and women are susceptible, and so a physical exam and appropriate testing should be performed when indicated. And so the screening intervals for syphilis for pregnant women needs to be done at the first prenatal visit, early in the third trimester, and then if they're high risk at delivery. For men who have sex with men, at least annually if they're sexually active, and then for HIV-infected persons, it's at the first HIV evaluation and then at least annually thereafter. So trichomonas, the CDC recommends, USPSTF didn't actually have any recommendations regarding trichomonas, but the CDC recommends to consider screening in women receiving care in high prevalence settings such as STD clinics and correctional facilities, and for those at high risk, having multiple sex partners, transactional sex, illicit drug use, and history of STDs in high prevalence communities. And then the CDC also recommends screening HIV-infected women who are sexually active at their initial evaluation and then annually thereafter. Herpes, so the USPSTF recommends against routine serologic screening for genital HSV infections, and that's a grade D recommendation. For transgender men and women, a physical exam and appropriate testing should be performed when indicated. And then the CDC recommends that type-specific testing be considered in those who present for an STD evaluation, especially if they've had multiple sex partners, if they're HIV positive, and if they are men who have sex with men. For hepatitis B, the USPSTF recommends screening for HPV infection in persons at high risk, and that's a grade B recommendation. So that includes persons born in a country with a prevalence of infection that's at least 2% or greater. If they're U.S. born, they're not vaccinated as an infant, and their parents were born in a geographic region with a prevalence of 8% or greater. I guess you have to go to the CDC to look up the prevalence in different countries. If they're men who have sex with men, if they're HIV positive, if they're an injection drug user, hemodialysis patients, if they're on cytotoxic or immunosuppressive therapy, and then if they have an elevated AST or ALT of unknown etiology. And then screening is also recommended in pregnant women, infants who are born to hepatitis B surface antigen positive mothers, and then if there's household contacts or sexual partners with HPV. For hepatitis C, the USPSTF recommends screening in those at high risk for infection, and that's a grade B recommendation. And then they recommend the one-time screening to adults born between 1945 and 1965, and that's also a grade D recommendation. Again, risk factors include past or current injection drug use, receipt of a blood transfusion before 1992, long-term hemodialysis, incarceration, intranasal drug use, getting an unregulated tattoo, and being born to an HCV-infected mother. And then all transgender persons who inject soft tissue fillers or share syringes should be screened. So HIV, the USPSTF recommends screening adolescents and adults 13 to 64 at least once, and then younger adolescents and older adults who are at increased risk should also be screened, and that's a grade A recommendation. And then the repeat screening is based on HIV risk assessment. The USPSTF for most of these doesn't put out any guidelines that address screening intervals. And so a lot of the screening intervals comes from the CDC. And then men who have sex with men should be screened annually if sexually active, and the patient or his partner has had more than one sex partner since the most recent HIV test. So this is just a map of HIV diagnosis in the U.S. in 2017, and so we can see Louisiana is this nice, brighter blue. We're behind Georgia and Florida, not by much, but this is new HIV diagnoses based on transmission categories. So we can see male-to-male sexual contact makes up the majority, 66%, followed by heterosexual contact. And then race or ethnicity, Black and African Americans are more affected, 43%, as compared to whites and Hispanics, who are actually 26%. And then this is just kind of putting both of those together, and so we can see Black men who have sex with men are going to be the highest risk category, followed by Hispanic men who have sex with men, and then white men who have sex with men. So transgender populations have higher rates of HIV infection than the general population, and death rates due to AIDS is estimated to be about 30 times higher for these individuals. And the CDC estimates that approximately a fourth of transgender women are actually living with HIV. HIV infection rates in transgender men are not well documented, but they may engage in high-risk behavior due to wanting to belong in gay male communities, including HIV-positive circles. Similarly, documentation of female-to-female HIV transmission is controversial, but again, that population can become infected through other risky behaviors. So HIV prophylaxis, condoms are the mainstay of prevention, and consistent use decreases the risk of acquisition by about 80%. They can be problematic, specifically for the transgender population, though. And so pre-exposure prophylaxis is the use of antiretroviral drugs to reduce the risk of sexual HIV acquisition in high-risk individuals. And post-exposure prophylaxis is the use of antiretroviral drugs after a single high-risk event to stop HIV seroconversion. So PrEP, the USPSTF actually has a statement regarding PrEP now. So it's a grade A recommendation that clinicians offer it to persons who are at high risk of HIV acquisition. I think this just came out over the last year. And these are the people who should be considered for PrEP. So men who have sex with men, are sexually active, and have one of the following: a serodiscordant sex partner, inconsistent use of condoms, or another STI with syphilis, gonorrhea, or chlamydia in the last 6 months. If they are heterosexually active, women or men with one of the following: a serodiscordant sex partner, inconsistent use of condoms during sex with a partner whose HIV status is unknown and who's at high risk, or a STI with syphilis or gonorrhea in the last 6 months, or persons who inject drugs and either share their drug injection equipment or have a risk of sexual acquisition of HIV. And so PrEP is daily Truvada. Studies have shown that it reduces the risk of getting HIV from sex by about 99% when taken daily. In injection drug use, it reduces the risk by about 74% when taken daily, and obviously those rates go down if not taken consistently. You must exclude acute and chronic HIV infection prior to prescribing PrEP, and then there is no contraindication between hormone therapy and Truvada in the transgender population. And so this is just a summary of guidelines for PrEP use, determining if they're at risk, and then you need to document a negative HIV test, make sure they don't have any signs or symptoms of acute infection, check their renal function, make sure it's okay, and then check their hepatitis B infection and vaccination status. And then typically it's given in 3-month supplies or less. It's not given more than that. And then they follow up at least every 3 months, and they get an HIV test, counseling on medication adherence, and behavioral risk counseling, assessing for any side effects and other STIs. And then you're assessing renal function at 3 months after starting, and then every 6 months thereafter. And then every 3 to 6 months, you're also testing for other bacterial STIs. So NPEP is kind of what they use for non-occupational post-exposure prophylaxis now. So it needs to be started as soon as possible to be effective, always within 72 hours of a possible exposure, which could include unprotected sex, needle sharing, injection drug use, or sexual assault. And it's usually a 28-day course of a 3-drug antiviral regimen. When I actually gave this talk a couple of years ago, I think there was only one recommended regimen. Now there's several. And so I didn't list all of those. But this is basically the evaluation for doing post-exposure prophylaxis. You want to get the HIV and hepatitis B status of the exposed person and the source, if available. Find out the timing of the potential exposure, what type of event it was, and if it's indicated, you want to do an HIV blood test. You want to also test for other STIs, HPV, HCV, pregnancy, chemistries, and then they get the 28-day course. And obviously you want to talk to them about medication adherence, potential side effects, and then when necessary, there are assistance programs that can help with getting the medication. So lastly, we're going to go over some vaccine recommendations. So for hepatitis A, universally recommended for all sexually active gay and bisexual men. So the ACIP, Advisory Committee on Immunization Practices, recommend that all of the following be vaccinated. So all children at age 1 year, those with unstable housing or homelessness, those at increased risk for infection, which include traveling or working in countries with high or intermediate endemicity, MSM, users of injection and non-injection drugs, if they're an occupational risk, for example, lab setting. Those with chronic liver disease, clotting factor disorders, if they've had direct contact with someone with Hep A, and household members and close personal contacts of adopted children newly arriving from countries with endemic disease. If they're at increased risk for complications from an infection, you want to also vaccinate them, and any person wishing to obtain immunity For just the Hep A, it's 2 doses with at least 6 months in between. You can combine it with the Hep B vaccine, though, in the Twinrix. And that's 3 doses at 0, 1, and 6 months. So hepatitis B, again, universally recommended for all sexually active gay and bisexual men. And then all of the following should be vaccinated: infants, unvaccinated children less than 19 years, men who have sex with men, sex partners of Hep B, surface antigen positive patients, sexually active partners who are not in a long-term mutually exclusive monogamous relationship, those who seek evaluation or treatment for an STI, if they're current or recent injection drug users, if they have hostile contacts with a positive person, again, occupational exposure, dialysis patients, diabetes, 19 to 59 years, chronic liver disease, HIV, positivity, incarcerated, if they have Hep C, and then international travelers to countries with endemic HPV. HPV is recommended for everyone through age 26. 2 doses are recommended for all children beginning at age 11 to 12. If they start the series on or after their 15th birthday, then they actually get 3 doses. Meningococcal, so there's 2. There's ACWY, and that's recommended in all 11 and 12-year-olds with a single dose with a booster at age 16. And then adults at increased risk, which include a complement component deficiency, functional anatomic asplenia, HIV infection, occupational exposure, travel to countries where the disease is common, first-year college students who live in a residence hall, military recruits, and then men who have sex with men with an epidemiologic exposure to other men who have sex with men from New York City or Los Angeles. And then serogroup B is the new one on the market, Bexsero or Trumimba. And so that's recommended for adolescents and young adults, 16 to 23. So they say that they can receive the vaccine. Those who definitely should receive it, though, are those with complement component deficiencies and if they have functional or anatomic asplenia, so our sickle cell patients. Pneumococcal, so I posted this, and if anybody's in clinic, they know I've posted this in the clinic too, because I understand it kind of gets confusing. But basically, know that so HIV infection, they're going to get the Prevnar, so PCV13, after age 19, and then it's also recommended that they get the Pneumovax. Flu, recommended for all persons 6 months and older annually. These are some resources for providers. So the Gay and Lesbian Medical Association, they have some guidelines for care of lesbian, gay, bisexual, and transgender patients. UCSF has guidelines as well for the primary and gender-affirming care of transgender and gender non-binary people. The Fenway Institute is a really good resource, and they have a lot of education materials. And then WPATH, the World Professional Association for Transgender Health. And those are all my references. Any questions? Yes.
Thank you very much. That was tremendous. Really appreciate it.
Thank you.
There's two things I'd like to say. One is that along with our HIV services to the community, that we do have a PrEP clinic in our infectious disease clinic.
Awesome.
And that's Dr. Abby Arts in charge of that.
Perfect.
The other thing is the United
Does
States.
Medicaid
Sorry?
pay? Does Medicaid pay for PrEP?
Yes.
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 Yes. Okay.
One way or another, it gets sorry, it gets paid for.
Yeah.
The other thing was the United States Preventive Services Task Force has recently recommended that Hep C screening be done for everyone between the ages of 18 and 79. It was just out for public comment so far. The public comment ended in September, but that's the way we're moving forward with hepatitis C. And if you have hepatitis C, we also look after that part of the disease. And we'd love to look after many, many more, because we know there are thousands out there.
Thank you.
And you mentioned that you may not have this number, Dr. Conlon may know, You mentioned about the Truvada reducing the risk of HIV from drug injection,
Yes.
74%. Do we have the numbers on the sexual transmission?
99.
That's the question.
99%.
99%.
99%.
That's the
For
question
sexual.
that most of us are going to get asked by our patients.
Yes.
Is, hey, if I'm having sex with these people, how effective is this? And it's that high?
Yeah, 99% for sexual transmission, 74% for drug use, and then again, that's with daily use, it goes down. But studies have actually looked at, there are specific studies looking at how often they take it as well, and we know that even taking it, you know, for example, like 3 days a week or 4 days a week is better than nothing. So.
Haven't been out of the office setting for several years. Those are things that I don't come across as much, but I still get asked those things by friends and family members in the community. They ask me those questions. I don't get.
Yeah.
That's tremendous. I had no idea what that was.
Yeah, and I actually didn't know that PrEP was now part of the USPSTF recommendations until I started updating this PowerPoint. And like I said, that's come out in the last year as well. So.
Thank you.
Amanda, one of the big issues is transition of care.
Yes.
Many of these individuals actually seek acute care but require follow-up care.
Yes.
What processes do we have, or what would you like to see to facilitate this?
So, I mean, being a med-peds person, I think we offer a good resource to be able to transition these people. We are pretty close with the pediatric and adult endocrinologist, and I reached out to them before actually doing this, and I know they're more than willing to always help us treat these patients and take care of these patients. But I think being in a center that can offer all of that really helps. And then, like I said, just for us as med peds, we're used to transitioning people, and so we offer, offering consistent care. The mental health resources for patients who are transitioning transgender. I haven't found that there are a lot of resources in this area for those, and Dr. Yadavelli or Dr. Scarborough may know more, but the mental health resources is something I find that, at least when researching, that we're lacking in the area. And so I don't remember the quote. I think there are some providers in Texas, but for transgender, that's the big issue, is the mental health aspect.
What about pharmacy support? We're finding that increasingly important in a variety of other outpatient environments.
Yeah, as far as like the hormonal therapy and everything.
Yeah, or actually pharmacists participating in the clinics for a lot of these other reasons.
Yeah, so I haven't, I know Dr. Beal has a lot more patients and could probably speak more. I haven't had an issue with getting the hormone therapy for patients. I've only seen one in the general medicine clinic outpatient with another resident, and as far as I know, he was able to get his testosterone without any problem. And so I haven't seen that it's a problem to get the medication. Yeah.
Other questions? I have one more. So I always like to leave these with a question about what we could do better, but particularly a research question. So, I mean, what question do you have that we could help identify in terms of either resource utilization or improving the care that we should be looking at doing research on?
Yeah, so the transgender research in general is lacking, so we don't have a lot of data on the effects of hormone therapy long term, especially on like cancer rates and risks and that type of thing. And so even cardiovascular risk, a lot of times, going back through autopsy reports and things like that, the fact that they're transgender, it's not included. And so we don't have a lot of that data to say. Suicide rates, even, they were saying that data is lacking. So that's something research-wise I think we could be better on. And then personally in our clinic, I think just being more inclusive, making sure we have the gender-neutral restrooms as opposed to just, male and female restrooms, making sure that we're, again, promoting confidentiality, making patients feel open and welcome, and promoting LGBT health here. I mean, I think these patients need somewhere, and I mean, everybody deserves to have good health care. And so doing what we can to encourage that and make them feel included in an inclusive environment, I think that would be beneficial to everyone.
Thank you so much.